Hi, everyone. We'll give just a few minutes to let everyone join us. Okay, I think I'll start with the introductions as people trickle in. It's my pleasure to introduce Dr. Andrea Tovar Garza. Dr. Garza is a board-certified dermatologist and founder of Unique Dermatology. She is currently practicing in Monterrey, Mexico. She attended medical school at the University of Monterrey and did her residency program in dermatology at the Dermatologic Institute of Jalisco in Guadalajara, Mexico. Then she did a 2-year research fellowship at UT Southwestern Medical Center with Dr. Amit Pandya, specializing in pigmentary disorders and skin of color. So it's my pleasure to hear Andrea's talk today about surgical interventions for vitiligo.
Vitiligo is definitely one of my areas of interest. So a lot has happened in the vitiligo area in the last few years, and I'm gonna make my best effort to just summarize from basic science and translational research to new therapeutic treatments and surgical interventions for vitiligo. I do not have any disclosures. So vitiligo is an autoimmune disease, and we know that it affects around 0.5 to 2% of the population worldwide. And this may not seem like a lot. However, this does represent from 35 to 70 million people worldwide. And we know that it affects over 3 million Americans as well. The estimated annual cost of vitiligo is $175 million. And this is actually significantly high considering that there are very few effective treatments for vitiligo. And as vitiligo specialists, we advocate that vitiligo should not be treated as a cosmetic condition, since we know that our patients have 5 times greater risk of depression and they have a quite significant quality of life burden due to this condition. Several mechanisms have been implicated in melanocyte loss, and we know that everything starts with genetics. And Dr. Richard Spies and others researchers around the world have identified over 50 genes associated with vitiligo. And they are mainly related to immune regulation, but they're also related to melanocyte function. And we know that it is actually a relationship between these two that increases the risk of having vitiligo. And epidermal cells, as well as melanocytes, are in constant stress, from UV radiation to exposure to different chemicals as phenols that are in hair dyes and other types of products. And we know that this increases the production of radical oxygen species. And in normal conditions, these melanocytes are supposed to cope with this type of stressors. However, melanocytes from vitiligo patients are not able to adapt, and usually this leads to loss of melanocytes as well. There are genome-wide studies that also increase the risk of NK cells and also increase the production of pro-inflammatory proteins such as heat shock proteins and specifically HSP70 as well. And there is also an increased production of other cytokines as well. So we know that the innate immunity in vitiligo patients is also affected. And finally, today, we understand even more the effect of cytotoxic CD8 positive T cells in disease progression in vitiligo. So everything, started in 1996 with a paper published by Caroline Lepool, where she basically identified the presence of T cells in areas close to loss of melanocytes. And a few years later, these cells were identified as CD8 positive T cells. And this paper, published in 2009, was published by the Netherlands vitiligo group. And it was very interesting because they took vitiligo lesional skin and then they cultured these CD8 positive T cells, and they reintroduced the CD8 positive T cells into non-lesional skin. And they found that there was, again, loss of melanocytes from these CD8 positive T cells. So they basically showed that both CD8 positive T cells are necessary, but also sufficient for disease progression. And multiple studies today have also shown that in vitiligo patients, there is an upregulation of interferon gamma. We also know that there is a loss of melanocyte transcript, and this does make sense since patients have depigmentation. And we also know that vitiligo patients express interferon gamma dependent chemokines, mainly CXCL9 and CXCL10. And all of these recent publications have shown that patients have an interferon gamma dominant response. So I really like this diagram because I think it summarizes very nicely the pathogenesis in vitiligo. So we know that there are these CD8 positive T cells that come from the bloodstream and then they crawl into the skin. They produce interferon gamma, and this signals through its receptor and activates JAK1, 2, and STAT1 pathway. And this induces CXCL9 and CXCL10, which then binds to its receptor. And this is what leads to loss of melanocytes. Obviously, the CD8 positive T cells also recruit more autoreactive T cells, and this is what starts everything in regards to depigmentation. So it is very interesting that, now we understand a lot about the mechanism and the pathogenesis in vitiligo. And this actually leads to new targeted therapies. And today we have, JAK inhibitors as tofacitinib, ruxolotinib that we know are effective in order to achieve repigmentation in our vitiligo patients. However, I think every vitiligo specialist understands that our vitiligo patients are very demanding in the sense of they have very high expectations. They want 95% repigmentation. And usually when you start explaining, the treatment to them, the first question is, doctor, but is this a cure? Or am I gonna be on treatment, for the rest of my life? And what's gonna happen after I discontinue my treatment? Is it gonna come back? So this is a very, classic vitiligo patient that I see in clinic. You see that she has extensive vitiligo at baseline, and you can see that she has over 75% improvement after 1 year of treatment. This patient has been on phototherapy, on oral mini-pulse steroid, as well as topical corticosteroids. So the patient was very happy with the response. So she basically discontinued treatment after a year. And this is her 4 months later. She came back to my clinic complaining that she had lost the repigmentation. So today we actually have an explanation for this disease recurrence. And in the last few years, Julien Seneschal's group from France, as well as other researchers from Sweden, have shown that there is presence of resident memory T cells in active vitiligo patients, but also in stable patients. And this is potentially an explanation of why patients recur. And the presence of these resident memory T cells also produce interferon gamma, as well as CXCL9 and CXCL10. So John Harris's group initially found that lesional skin biopsies from patients with vitiligo actually contain antigen-specific CD8 positive resident memory T cells. And they showed in their mouse model that by decreasing or blocking the recruitment of these recirculating resident memory T cells using FTY720, or also just by depleting the amount of cells by using Th1.1 depletion antibody, you can see that the mouse model tail actually showed repigmentation. So they established that these tissue resident memory T cells and these recirculating resident memory T cells could potentially be a target and a more durable, treatment for vitiligo. Now, these resident memory T cells actually require IL-15 to survive. And they also show that IL-15 deficient mice have impaired resident memory T cells. And they treated their vitiligo mouse model with 3 times weekly intraperitoneal CD122 antibody. And this actually blocks IL-15 signaling. And what they found is that after 8 weeks of systemic treatment, they saw that the mouse tail actually repigmented. And they later treated again with intradermal injections of CD122 antibody for 4 weeks, and then they stopped treatment and they saw that there was continued repigmentation on the mouse tails, which means that short-term treatment with anti-CD122 could potentially be a more durable repigmentation treatment for our patients. So new evidence has shown in this diagram that it is not only the presence of these CD8 positive T cells, but also the presence of these resident memory T cells that are left behind even after patients have repigmented. And we know that these cells also produce interferon gamma, and they produce as well CXCL10 and CXCL9. And this leads again to loss of melanocytes and also to more recruitment of these resident memory T cells. So by blocking IL-15, it is one way to basically block these resident memory T cells. However, we do know that there are other ways as well to block these resident memory T cells. And this is still ongoing research to see which one could potentially be more effective or a more eligible or feasible treatment for our patients. So now that we understand, the mechanism behind vitiligo, now how do we treat these patients? And I think it's very important for every dermatologist to be able to recognize active vitiligo in our patients. And this is important because if we are not aggressive in treatment with these patients, then they are going to depigment very fast. So we have trichrome vitiligo, which is characterized by this area of hypopigmented zone in between normal skin and complete depigmentation. We have Kevner phenomenon, which I think every dermatologist obviously is familiar with, and it is this linear-like depigmentation. And we also have the presence of confetti-like vitiligo. And this was a sign that was described by Dr. Piania's group, and it is characterized by the presence of multiple depigmented 1 to 5 millimeter macules that usually appear in clusters, and they tend to appear around pre-existing lesions. So, how often are you going to see this in clinic? And we published this paper, and we basically showed that close to 60% of patients have at least one marker of disease activity. So this means that most patients are going to need aggressive treatment from the start. And early intervention could potentially even prevent the accumulation of these resident memory T cells. And this is the importance, to identify and to start early treatment on our vitiligo patients. So now that we have described the different mechanisms, we can start targeting like one by one so we can have an effective treatment for vitiligo. And we know that successful vitiligo treatment requires a combination of these therapeutic options. And I'm not going to talk a lot about decreasing melanocyte stress just because there is not enough time, but there are studies that have shown that the use of antioxidants, specifically, vitamin C, vitamin E, and alpha lipoic acid, this does increase the rate of repigmentation when it is combined with phototherapy and when it was compared with placebo. Now, let's start with immunosuppressants. Topical steroids are level 2 evidence of treatment for vitiligo, and we know that in the body we can use ultra-potent or potent corticosteroids. Usually in areas like the face, neck, and intertriginous areas, we can use mid-potency steroids. And in clinical practice, we have seen that cyclical application does decrease the risk of side effects, and it also increases patient compliance. However, we do need evidence-based data to confirm this. And I do use the 5 consecutive days and 2 days off on topical steroids for my vitiligo patients. Now, topical calcineurin inhibitors are also level 2 evidence, and they are usually first-line treatment for sensitive areas such as the head and neck. And we know that they are effective in these areas, but we also prefer them due to their safety profile. And in this systemic review, there was a moderate response in 48% of children who were treated with topical calcineurin inhibitors as monotherapy. However, we do know that it is much more effective if you combine this with phototherapy. And another systematic review compared the effectiveness of topical calcineurin inhibitors and topical corticosteroids. And actually, calcineurin inhibitors showed similar effect on over 50% repigmentation when it was compared only to mid-potency corticosteroids. However, super potent corticosteroids have higher efficacy than calcineurin inhibitors in achieving over 50% repigmentation. And in pediatric population, when these two groups were compared, there was no significant difference. So usually in children, especially in lesions over the face and neck, we do prefer the use of calcineurin inhibitors. So moving to other topical immunosuppressants. And I think this is, a very exciting time in vitiligo because these are actually new emerging treatments. And this is a study, it was a multicenter randomized double-blind phase 2 study that evaluated multiple concentration or different concentrations of ruxolotinib. And we know that this is a JAK1/2 inhibitor. And patients were actually set on different groups. And then at week 24, the patients were re-randomized from placebo and from the lowest dose group to the 3 higher doses. And as you can see, facial VASI 50 was achieved by week 24, usually in 50 and in 45% of patients on the highest dose group. And facial VASI 75 was reached in 52% of patients on the dose of 1.5% BID by week 52. Now, what about the total VASI 50? So this was achieved at week 52 by 45% and 37% of patients on the 1.5% once daily as well as twice daily group. And this is actually a pretty good response considering they were on monotherapy. So in this study, there were 2 centers that also measured CXCL10 in serum of these patients. And as you can see in this graph, there was a decrease in the highest dose group, and especially in the group who was on 1.5% BID, there was a decrease of 20% at week 24 and a decrease of 22% by week 52. And I think it's very important to mention that there was no correlation to systemic concentration of ruxolotinib, which is very important. Now, what about the side effects? So side effects were usually mild, patients usually complained of pruritus at the site of application as well as acne. And there were no clinically relevant changes in lab values. There was only some mild shift in hemoglobin as well as platelet count. However, these values returned back to normal by week 52. So the results of these publications are very interesting because they basically established that topical ruxolotinib is an effective and successful treatment for vitiligo, and that there is probably no need for oral JAK inhibitors. And this is obviously a much feasible option also because there is less risk of side effects. And this study actually was ongoing after week 52, and patients were allowed to add phototherapy as well to topical ruxolotinib. So I am very excited, to see the results of this paper from my colleagues. And this is a patient that was initially on placebo for the first 24 weeks. And you can see that afterwards, she was switched on 1.5% once daily, and she's achieved over 75% repigmentation by week 52. This is another patient who was in the highest dose group with 1.5% twice daily. And you can see that she achieved over 75% repigmentation by week 52. There are other types of JAK inhibitors, and tofacitinib is one of them. This is a JAK1/3 inhibitor, and there are case series published on this medication. This is a publication from Dr. Peña's group. They had 11 patients on topical 2% tofacitinib twice daily, as well as phototherapy 3 times weekly. And this is the result of one of their patients. They usually saw good to excellent repigmentation over a period of 2 to 4 months. And this is another case report of a 4-year-old with segmental vitiligo who achieved over 90% repigmentation while on topical tofacitinib twice daily, as well as a handheld unit narrowband UVB. Now, let's move towards oral immunosuppressants. And oral corticosteroids, have been used in the past, and it was, the alternative that we had when we had an active patient. And the main purpose, to start this is actually to halt disease progression. And in this table, you can see, all the published data on oral mini-pulse corticosteroids. And usually doses range from 2.5 milligrams to 10 milligrams. We obviously know that the higher the dose, the greater the risk of side effects. And we published this paper on the JAD on 4 milligrams oral mini-pulse dexamethasone. And we actually showed that 92% of patients achieved disease stability at 3 months, compared to 53% of our patients on the control group. The side effects were present in 28% of our patients. They were usually mild and mainly consistent of insomnia, weight gain, as well as steroid-induced acne. And we also found that patients on the oral mini-pulse group had actually higher repigmentation at follow-up when compared to control group. And one of the main reasons we prefer oral mini-pulse is the safety profile. So this is a publication from the JAG that evaluated plasma cortisol and corticotropin levels 24 hours after the oral mini-pulse. And as you can see, 24 hours after the second dose, there was a dramatic drop of cortisol and corticotropin levels. However, this was only transitory, and by day 3 and by day 4, these levels returned back to normal. And now moving to other oral immunosuppressants, and oral JAK inhibitors, specifically tofacitinib, is one of the new alternatives or targeted therapies. And this paper was actually the paper that started, everything on new pathogenesis-directed therapy for vitiligo. This is a paper that was published by Dr. Brett King, and they treated their vitiligo patients with tofacitinib 5 milligrams BID. And as you can see, she had over 75% repigmentation at 5 months follow-up, even in hard to treat areas such as the hands. And this patient did not report any side effects, and there were no lab abnormalities. So since then, there has been multiple publications on the use of oral tofacitinib with and without phototherapy. Oral ruxolotinib, which is a JAK1/2 inhibitor, is another therapeutic option. This is a paper published by John Harris's group, and this patient had, near complete depigmentation on the face, and he also had concomitant alopecia areata. So you can see that by week 20, the patient had over 50% repigmentation. However, after discontinuing oral ruxolotinib, this patient lost the repigmentation. So another interesting thing about this paper is that they also measured serum CXCL10 levels, which actually, remained high while the patient was on placebo. But after starting ruxolotinib by week 12, there was a dramatic and significant decrease of CXCL10. Now, what about the use of concomitant, phototherapy with JAK inhibitors? So this is a paper published by Dr. Brent King and John Harris, and they actually noted that the patient's sun-exposed areas did repigment, as you can see in the forearms, in the dorsal hands, as well as the upper chest. However, some protected areas, such as the intramammary fold, did not repigment. So they did flow cytometry to evaluate CD8 positive T cells, and they did ELISA to evaluate CXCL9 and 10. And what they found is that both responsive and non-responsive areas did show a drop in CD8 positive T cells as well as chemokine values, stating that tofacitinib was effective, but it was not enough to achieve repigmentation. So probably repigmentation actually requires both. It requires a suppression of the immune system, which can be achieved using JAK inhibitors, but it also requires light exposure. And this could even potentially be targeted with low-dose phototherapy. So even with JAK inhibitors available, phototherapy remains an old but goody treatment. And this is a systematic review and a meta-analysis published by Zhang Mei's group, and they basically studied 35 prospective papers, most of them on narrowband UVB and some on PUVA, and they observed that over 75% repigmentation was achieved mainly on narrowband UVB when compared to PUVA. They also showed that face and neck is usually the areas with the best response. This usually followed by the trunk and extremities. And we know that hands and feet are, hard to treat areas even with phototherapy. So overall, the response is superior using narrowband UVB versus PUVA. And we also know that color match is much nicer using narrowband UVB. Now, what is the response timeline for these patients? So this was a paper that basically showed with narrowband UVB phototherapy, you can have 25% repigmentation at 3 months, 50% repigmentation at 6 months, and 75% repigmentation at 9 months. And I think this is very important to discuss, with your patients. You have to let them know that this is, a long treatment, that it's gonna take time, because if you do not set the expectations clear with them, then they're gonna drop out at 3 months because they are not seeing 50% repigmentation. And obviously this is not something that is feasible in vitiligo. So Dr. Cabrera's group from Chile published this amazing paper, and they created a predictive model of repigmentation according to patients' response in the first 48 sessions. And they also described a new subset of patients who are slow responders. And this is usually patients who have, low repigmentation by 4 months. But then if you continue phototherapy, they even saw greater than 40% repigmentation in these patients at 96 sessions. And they also established a new definition for non-responders, which is less than 10% repigmentation after 96 sessions. Now, a lot of physicians are probably thinking, I know phototherapy is effective, I know it works, but I do not have a phototherapy unit in my clinic, or, those who do have a phototherapy unit, some patients just don't live close to your office, and this is not an eligible treatment for them. So Dr. Peña's group published this paper, and this is a cross-sectional study comparing the use of home versus in-office phototherapy. And they showed that the mean treatment time is actually much shorter in home phototherapy versus in-office phototherapy. They also showed that in-office cost actually exceeds that of home phototherapy by 3 months. And this is also very interesting because you can't get insurance companies to cover for, some phototherapy units for your patients, just because it is going to cost them even, higher to have them in your office than to get a home unit for them. They also showed that there was similar repigmentation in both groups at 6 months, and adverse effects were also mild. This is a paper, an earlier publication actually published by the Netherlands group, and they also showed similar results and even slightly higher risk of blister formation in the in-office group. And they showed that there were similar repigmentation rates for both home and in-office phototherapy. Therefore, you should be considering home phototherapy as an option for your patients, even if they do not have access to an in-office phototherapy unit. So maintenance treatment is very important, and we know that vitiligo patients tend to recur 40% of them during the first year after discontinuing treatment. And there are, 2 protocols or 2 ways to continue patient on maintenance treatment. One of them is to just taper down the phototherapy sessions, and you can do this over a 2-month period or even over a 4-month period. Obviously, if the patient recurs in this timeline, then patient has to go back to standard treatment. And Dr. Thierry Passeron published this paper on the use of tacrolimus 0.1% twice weekly, and they showed that there was a decrease of disease recurrence from 40% to 10%. They obviously showed that it was more effective on areas like face and neck. However, it was effective as well on other body parts. So to recap, for active vitiligo patients, we need to be aggressive and we need to use everything we have. So we need to use antioxidants, oral mini-pulse steroids, topical JAK inhibitors, as well as phototherapy. And what about as our stable patients? So our stable vitiligo patients, we have other treatment options to offer. And there are several types of surgical procedures that we can do on these patients. So I think the most important thing is to establish, what disease stability is in vitiligo, especially if you're considering a surgical intervention for them. So we have established, obviously, that stable vitiligo means the absence of these active sites of vitiligo for the last 6 to 12 months. And I have, previously stated what they look like. We also need to have absence of new lesions in the past 6 to 12 months. And this was a paper published by Dr. Peña's group, and they actually showed that ideally you should have photographic evidence of absence of new lesions because patients' recollection of new lesions is not very accurate. We know that our segmental vitiligo patients are the best candidates. However, we need to have in mind that segmental vitiligo patients tend to be active in the first 2 years of disease onset. So these patients should be on medical treatment beforehand so we can assure their disease stability. There are multiple types of surgical treatments for vitiligo, from tissue grafting techniques to cellular grafting techniques. So today I'm going to discuss just a couple of them, just because there is not enough time. And let's start with punch grafts. So punch grafts is one of the most common surgical techniques for vitiligo, and I like it because it does not require any expensive material for you to perform. So usually common areas to obtain the donor tissue are upper thigh, the hip area, and even the buttocks. And one very important thing in this procedure is the depth of the recipient side as well as the donor side. So usually in the recipient side, you have to go all the way down into the subcutis. However, the donor side, you have to be very superficial and only reach the papillary dermis. Usually, the recommended distance between grafts is 5 to 8 millimeters, and common side effects are mild scarring, cobblestone appearance, as well as milia-like formation. So in this diagram, you can see the depth of both of the punch grafts. So you can see that in the recipient side, you do have to go all the way down into the subcutis. However, in the donor side, you have to be, more superficial. And these actually, come up like muffin tops. And on the right, you can see all the material that is needed to actually perform a punch graft, which is pretty standard. And we do use 1 millimeter punch size for areas on the face, and we use 1.5 millimeters for the rest of the body. So you estimate the punch grafts on your recipient side, and then you apply lidocaine with epinephrine in the recipient and as well as the donor side. Then you go and remove the punch grafts from the recipient side and you apply hemostasis. This step is very important because there should not be any bleeding in this area. If there is even the slightest bleeding, then it's gonna drive your punch graft away. Then you go into the donor side. Again, you estimate and you remove these punch grafts all the way into the papillary dermis. And then you transfer this into a wet Tovar gauze and you transfer this into the recipient site. And what we do is that we apply Steri-Strip dressing and we leave this for 1 whole week. So the initial repigmentation is usually seen at 2 to 4 weeks. The average spread is usually 6.5 millimeters. It can be much higher, especially in dark skin patients. Usually 50 to 65% of patients achieve over 75% repigmentation. And we know that stable patients obviously are gonna have a higher percentage of repigmentation when compared with active patients. And maximal repigmentation is on average seen at 3 months post-surgery. And this is a patient of mine with segmental vitiligo, and you see her follow-up at 4 months, where she achieved over 90% repigmentation. And as you can see, even on the upper eyelid, there was no cobblestone effect. And this is another patient with segmental vitiligo with over 90% repigmentation at 4 months. And we know that even after any type of surgical procedure, patients are continued on phototherapy because usually the response is much better when you combine this. And to end this lecture, I'm going to discuss MKTP. And MKTP is a cellular grafting technique. This procedure was originally described by Gauthier in 1991. And one of the major benefits of this procedure is the high recipient to donor ratio that you can have. And this basically means that you can treat a larger area with less donor tissue. So the original technique, which required, using a dermatome and obtaining the donor tissue from the scalp, The trypsinization process was actually long, around 18 hours, and they used liquid nitrogen as a blister formation method. And after obtaining the epidermal suspension, they actually injected the suspension into the blister. So the blister roof actually acted as a natural dressing. Today, this process has been modified, and we can actually perform this procedure in 1 day. And the trypsinization process is shorter by using an incubator and maintaining a temperature of 37 degrees Celsius. We have different methods of preparing the recipient site, from dermabrasion to novel techniques such as lasers. And after getting the epidermal suspension, then what we do is that we basically just apply it drop by drop into the recipient site, and we use a collagen dressing to keep the cellular suspension in place. Most surgical sites that perform this procedure use split thickness graft as donor tissue, and we do blister grafts. And there are, three major benefits from using blister grafts. One is that you do not require any specialized personnel to harvest the cells. The second one is that the scarring at the donor site is more aesthetically pleasing using blister grafts. This is actually a picture of the same patient. She initially underwent an MKTP procedure using split thickness, which is the picture on your left. And then the second one is the healing site from our blister grafts. And we also know that the healing time at the donor site is much shorter using blister grafts. So we prepare the donor site using this blistering machine, and it usually takes 20 to 30 minutes for them to be fully formed. Then we obtain the blister tubs and we incubate them in trypsin for 30 to 40 minutes in order for the cells to start separating. Then what we do is that we scrape the underside of the blister top. And this is actually one of the most challenging parts of the procedure, because it is quite difficult not to tear the blister. And if the blister, tears apart, then it is much harder to get the cells. Then we transfer the epidermal suspension into a 15-millimeter tube, and we add enough Ringer's lactate to complete 10 cc. And then we spin this in a centrifuge for 5 minutes at 2000 RPM. And this is the final, step where we get our cell pellet, as you can see in the picture from the right. We prepare the recipient site using an erbium jack laser, and we do this until there is mild pinpoint bleeding. And then once we have our cellular suspension, we basically apply on the recipient site drop by drop, and we cover this with a collagen dressing. This is a picture of a patient of ours with segmental vitiligo 1 year after her MKTP procedure, and you see that she has achieved over 75% repigmentation. It is very important to mention that studies have shown that even after the first year post-procedure of MKTP, you can still see repigmentation. And as you can see as well, the color match is very nice in our patients. This is another patient with segmental vitiligo after 10 months follow-up, and you see that she achieved over 50 to 75% repigmentation, and again with a very nice color match. So these are the centers, worldwide that perform MKTP. There are 3 centers in the US, and we are, very glad and proud to be the center in Latin America that performs MKTP. And I would like to thank especially our vitiligo community. This was a walkathon in Dallas, Texas, back in 2017. And I would obviously like to thank my skin of color mentor, Dr. Amit Pandya, and obviously, the rockstar in translational research in vitiligo, Dr. Jen Harris, for allowing me to collaborate with them in some studies. Thank you.
Well, that was excellent. I'm always impressed by the color match and the extent of repigmentation. It was just beautifully done. And I also wanted to mention that Dr. Tovar Garza did collaborate with John while I was a postdoc, Dr. Harris while I was a postdoc in his lab. And she was instrumental in providing the skin biopsies that we did to perform the staining for that IL-15 study. So just wanted to mention that. I don't know if we have any questions coming in the chat yet, but my question is, have you looked at any patients who have failed like treatment, surgical treatment, like if they get depigmentation again, do you provide an immunological treatment, and does that help? Like if you quell the inflammation after the surgery?
So usually I am very picky with my surgical patients. So I don't perform any type of surgical procedure unless it is a patient that I have seen at least for 6 months. So I'm certain that patients do not have any new lesions, you know, because we are following them up with photographs and everything. And definitely patients do have to be, you know, at least on phototherapy before considering the surgical procedure. So usually segmental patients, they tend to be active in the first couple of years, but there are some patients who are still active even after the first couple of years. So one of my first surgical like punch grafts in a segmental patient, he was referred to me by another physician. The patient was certain that he was stable, you know, for the last like year and a half. So I performed a punch graft and the patient actually depigmented even worse at follow-up. So this is why I am like, I do not do any procedures unless it has been my patient for several months. Just because even with segmental patients, you know, we know that there's not much activity, but still with these patients, we have seen this, you know, unfortunate surprises. So even with generalized patients, I am even more picky, and I definitely do, you know, everything, just topicals, phototherapy, and everything beforehand.
Yeah, makes complete sense.
Yeah, that's really interesting. So do you have them actually like prepare the site where you're going to do the transfer to ahead of time with something like steroids or calcineurin inhibitors or potentially a JAK inhibitor down the road?
Not really. So patients like they do not necessarily apply like topical calcineurin on the donor side, because you know these patients are probably on full body phototherapy beforehand. So that's usually, you know, my go-to option. And I have not actually seen any like Kepner phenomena on the donor sites of my transplant patients.
Yeah, that's excellent. We have a question from the audience. Is there any role for a DMARD like methotrexate to treat vitiligo?
So I do not use any methotrexate on my patients, and I know that there are several publications, you know, considering that it could also be an adjuvant therapy as immunosuppressive. But I think that, you know, with oral mini pulse, it's more than enough to stabilize the patients. So I do not have them on methotrexate at all.
Okay, we have another question. How does Avita Medical's red cell or RECELL, technology, which is in development, compare with other surgical treatments? I don't know if you're familiar with that, RECELL technology.
I'm not familiar with that one particularly, but I think all the RECELL technologies are like basically they have a kit and they do the whole process of the harvesting and the cell suspension and everything. So it is a very nice, you know, way to simplify the whole surgical procedure, because, you know, even you guys do it at UMass, so it takes a whole group, you know, to actually perform this procedure. Usually with the blister grafts, I know it's like a couple of hours or 3-hour procedure. I think with using a split thickness graft, it takes a little bit longer. But, you know, I do not have any experience with this technology because we do everything manually. So we do not use this. And my only concern with this is I don't know if the cost is quite high for our patients. So even just with the regular MKTP cost, it is not a procedure that a lot of patients can afford. So I'm not sure if this type of technology also pops the price up, and it's just not a lot of patients are going to be feasible to have this done.
Yeah, that makes sense. It's also very impressive that you and your center do the whole procedure and that you're the only center in Central America that does. It's very impressive.
Thank you. There was physicians in Chile who actually, a dermatologist who actually learned this from Dr. Pandya as well, and they were doing several procedures there. But I think just they kind of stopped because she was busy doing other types of research and stuff.
So I have another question, and it may be patient specific, but do you have a particular technique that you prefer? I know you've shown us, several different techniques. Is there one that you have found tends to work better, or maybe works better on a certain body site for your patients?
So usually for hands and feet, I prefer punch grafts just because, it's an area that has a lot of mobility. So I think it's easier for the punch graft to just like settle down. And it's a little bit harder to do MKTP because obviously the areas are irregular. So the cell suspension is much harder to just stay in place. For eyelids, I prefer either blister grafts, which I did not explain, but it's another procedure, or MKTP, because punch grafts tend to have you tend to have a lot of the cobblestone effect on the eyelids, just because you can't go that deep because the area is very superficial. So I do not do any punch grafts on the eyelids anymore. I did it on like a couple of patients and I didn't like the results that much. And specifically on large to treat areas, I directly go into doing MKTP.
Okay, we have another question. Besides therapeutic treatment, what are other needs vitiligo patients look for from their healthcare providers? So like, do you, refer them for like mental health or anything like that?
Definitely. I think, people who see vitiligo patients, they know that they are very anxious patients. And there is also a lot of, burden in their quality of life, even if they have a very low, vitiligo area affected. So this is something very important. We tend to undermine our vitiligo patients who just come in for like a couple of spots. And this is something that we should not do because studies have shown that their quality of life is not correlated with their disease severity. So I think it's definitely, you have to, make your whole team and refer them to psychology, to psychiatry, if it's a patient that you feel like needs that, additional benefit. And I think, everybody does, especially, vitiligo is not just something that stresses, like particularly our patients, but I think it's definitely something that you have to do as a group.
Yeah, excellent. I don't know, Bill, can you think of anything else?
Yeah, no, that was it's just such a wonderful overview, and I really appreciate the summary of the surgical techniques, and the technology is really neat. So yeah, it was a lot of fun to hear about. I'm curious, so if you have a patient with new active vitiligo that comes in, that's widespread and progressing, is your go-to is typically the oral mini pulse and then probably get phototherapy on board as well?
Yes, so unfortunately in Mexico, we do not have access, or most patients don't have access to oral JAK inhibitors. So that's not an option for me today. So right now, I definitely do oral mini pulse, phototherapy, and topical steroids on our patients, and the antioxidants as well. So I do everything at the same time.
And do you find that for most patients that you're able to get them under control doing that, or are there patients
Yes.
that are recalcitrant to, even?
So I think over 90% of patients get stabilized, at 3 months. So you also have to, talk to them about this. And then at 3 months, I just withdraw the oral mini pulse and I just leave them on phototherapy and topical therapy. There are some patients who take a little bit longer, probably like 5 months. So we have to continue them on oral mini pulse for a little bit longer. But I think it's very rare, for that patient that even, after 3 to 5 months on oral mini pulse, on phototherapy and topicals, that even gets worse. Like it does happen, but I think this is a very low percentage of patients that actually, progress very, very rapidly. And this is something very interesting because, with my colleagues that are dermatologists, but probably don't see a lot of vitiligo patients, they tend to think that it's the other way around, that there is not much that you can do, that patients are just gonna keep progressing. And this is not what I usually see.
That's very promising. So I think we're basically done. So I think we'll wrap up for today. Thank you so much, Dr. Tovar Garza, for taking time out of your clinic schedule to be with us and teach us all about surgical interventions for vitiligo. It was an excellent lecture. And as I mentioned, I'm always impressed by the photos, the after photos. So we look forward to meeting up with everybody again. Next month, we have 2 speakers, I believe. So thanks, everybody, and have a great rest of your week.
You too. Thank you. Bye-bye.